All right. Uh, Thank you, Pallium India, for this wonderful opportunity, and thank you um, to all the doctors who have joined this. It's always heartening to know that there are new groups of there are so many new groups of physicians who are showing more and more keen interest in palliative care and pain management and opioid management in pulmonology is one very important aspect which this course is looking at. I am going to focus primarily on opioids today. I will just talk a little bit about some aspects of pain assessment and the WHO step ladder, and not going to talk about opioids for other illnesses, for other symptoms like breathlessness, because I think that is going to be covered in the sessions to come. So I believe all this has already been covered. Today, we would like to talk a little bit about the overview of pain and opioid physiology. A little bit about the WHO pain ladder, which is what we palliative care physicians look at when we are trying to treat for pain. A little bit about the pharmacology of opioids with introduction on each of the opioids that we are currently using. The NDPS Act, which is the main act that determines prescription, it determines storage, it determines how opioids can be given by hospitals and medical centers, and a little bit about how opioids should be prescribed. So a bit of an introduction to prescription of opioids also. So beginning with pain assessment, we'll come to physiology a little bit later. This is the basic pain assessment tool that is used by a lot of palliative care medical personnel. The numerical rating scale and the visual analog scale. Usually we ask patients to tell us or to rate their pain from a scale of 0 to 10. We sometimes use 0 to 100%, or we sometimes use the 1 rupee scale, in which we ask them if it is 4 annas, 8 annas, 12 annas, 16 annas. That's more so for older patients or those who may not be able to count. Then there are other pain scales which are used for patients with dementia, patients who cannot verbalize. And even if you don't use this pain scale as a whole, look at some of the points that are mentioned over here. And these can be visual pointers or behavioral pointers for you to determine if a patient who is nonverbal is in pain. So vocalization in the form of whimpering, groaning, or crying, a change in the facial expression like grimacing or frowning, a change in the body language like guarding one area or withdrawn or fidgeting, behavioral changes like confusion and alteration in usual behavior, physiological change like change in temperature, pulse, respiration, flushing, perspiration. Physical changes like tears in the skin, skin looking pale, pressure areas, arthritis, or contractures. And so these are some of the points that can give you a clue that what you are dealing with is a patient in pain, even though they cannot communicate that they are in pain. So I have to thank Dr. Naveen Salins for this slide. This is the Indian adaptation of the WHO analgesic step ladder. If you see the areas from step 1, 2, and 3, that is the original WHO step ladder. This numerical rating scale and visual analog scale that I have shown you. If we look at 1 to 3, that is mild pain. We look at 4 to 6, that is moderate pain. 7 to 10 is severe pain. And so that's what step 1, step 2, and step 3 denote. Step 1 is pain management if the pain score is 1 to 3, which talks about using non-opioid medications, so paracetamol, NSAIDs, and other adjuvants. Adjuvants could be neuropathic medications, it could be steroids, it could be anticonvulsants, which can be used for neuropathic pain. Step 2 is at a pain score of 4 to 6. And here you will use the medications in step 1 plus weak opioids. So you will continue to use some non-opioid medications, NSAID, paracetamol, any of that, but you will also use some of the weak opioids. The weak opioids commonly used in India are codeine, tramadol, and tapentadol. We'll come to each of these in the later slides. And if you look here on top, you also include non-opioid medications and adjuvants. And then we come to step 3. Step 3 is at a pain score of 7 to 10. And along with all the non-opioid and adjuvant medications, you will use strong opioids. Now, there are a lot other strong opioids also available in the rest of the world, but these 4 are the ones that are available in India and the ones that are commonly used. They are morphine, fentanyl, methadone, and buprenorphine. Out of these, morphine is the one that is most commonly used by a lot of palliative care physicians. It's easily available, or at least easier availability as compared to the other strong opioids. Although fentanyl and buprenorphine patches are also pretty commonly available nowadays, but it's cheaper. It can be taken orally. It can be modulated. Dose can be modulated much quicker, and so morphine is usually the drug of choice and the starting drug. And a lot of our opioid calculation is based on the oral morphine dosage. And then we also have other patterns of pain management, which is interventional pain management, like neuraxial analgesia or nerve blocks. And this is in case there is incomplete relief with these medications, there are intolerable side effects, you are needing to give pain medications for a very long time, or a situational demand, like a special marriage or a special function coming up that the patient is requesting pain relief or better pain relief for. This is the other aspect of the WHO pain ladder. We now know what are the 3 steps on the WHO pain ladder, but there are some other principles by which we operate, which is pain management should be round the clock or by the clock. It should be preferably by the mouth. It should be by the WHO ladder, and there should be an individualized approach. By the clock means that a lot of the pains that we deal with in palliative care are either cancer-related pains or they are chronic pains. And chronic pain, one of the particularities of chronic pain is that even if the stimulus causing the pain goes away, the pain itself does not go away. Diabetic neuropathy is a kind of chronic pain. So continuous pain needs continuous relief, and drugs should be prescribed not SOS, not on an as needed basis, but on a round the clock basis. By the mouth is to give medicines orally as much as possible, because this is the simplest route. The patient needs no additional help or support and can be done by, and they can do it by themselves. By the ladder is choosing medications from the WHO ladder according to the severity of pain. An individualized approach means that every pain prescription should be tailored to the individual who is needing it. So that means choosing the right drug based on availability, based on accessibility. It means choosing the right route for the patient. Most of the times this will be oral, but if the patient is unable to take orally, or orally is becoming too cumbersome, then looking at other ways to do that. Choosing dosages based on comorbidities, based on drug interactions, and also mentioning doses for breakthrough pain, which is pain that can occur over and above the baseline pain relief that the patient is having. because one characteristic of cancer-related pain is that it is quite unpredictable. It can increase in intensity at any given point of time. It may not be related to movement or any particular thing that the patient has done. It could just increase by itself, and this is what breakthrough pain is needed for. Breakthrough pain is also needed for when there has to be a particular movement that the patient needs to do, and the pain gets aggravated at that movement each time. This could be like a dressing, this could be physiotherapy, this could be something else too. So we have now looked at a little bit, a very short introduction to how pain is assessed and the WHO pain ladder. Now we jump straight into opioid pharmacology. Before we get into opioid pharmacology, I just want to ask if there are any questions about pain relief or rather pain assessment or the WHO pain ladder that I have just shared.
Participants, you can raise your hand, unmute, and then ask questions. Dr. Smriti, I don't see any comments in the chat box as of now.
Let's go ahead. Okay. So coming back to the main meat of the talk, which is opioid pharmacology. Opioids, as we all know, are derived from the opium poppy. The chemical name or the scientific name is Papaver somniferum. There are 4 naturally occurring opioids, which are basically plantamines called as alkaloids. And these are derived from the poppy, and these are morphine, codeine, papaverine, and thebaine. Now, from and using these naturally occurring compounds, we have formulated semi-synthetic compounds and then synthetic compounds. So semi-synthetic compounds are diamorphine, which is heroin, dihydromorphine, which is not available in India, buprenorphine, which is available in India, oxycodone or Vicodin, which is a very strong semi-synthetic opioid that's actually, I think, responsible for the opioid pandemic that USA has been facing. And then we have the synthetic compounds that have been derived, and these are pethidine, fentanyl, methadone, alfentanil, remifentanil, and tapentadol. Out of these, what are available for us is all of these are available except for alfentanil and remifentanil. Pethidine is usually used for very short analgesia, so it's used for procedures primarily. Fentanyl, methadone, tapentadol are all used for pain relief. So this is just a short description of what are the opioid compounds. And now we move on to what are the opioid receptors present in the body. The receptors, there are 3 primary opioid receptors. These are delta, mu, and kappa. Later on, a non-opioid opioid receptor, so to speak, has been developed or has been discovered, which is known as NOP, which is noxiceptin opioid peptide. But most of our opioid pharmacology is focused on these 3 receptors, mu, delta, kappa. They are also known as MOP, DOP, and KOP. And the main analgesic effect is mediated through mu. So most of the opioid drugs are mu agonists. And I've also included some of the locations of the receptors which produce analgesia. It's important to know that we have endogenous opioids in our body anyway, and pain or any nociceptive stimulus produces these endogenous opioids. And that's the reason there are so many opioid receptors. That's the reason there are so many opioid receptors all over the body. So mu receptors can be found at the supraspinal area, at the spinal cord, and in the periphery. Delta receptors are primarily found in the spinal cord, and kappa receptors are primarily found in the periphery. And so we've already done a synthetic and semi-synthetic opioid-based classification, but now we are also doing a receptor-based classification. So if we look at it through receptors, there are 4 different types of opioids. There would be agonists, who will basically produce the maximal response from the receptor. Morphine is an agonist. There will be partial agonists who bind to receptors, but they will elicit only a partial functional response. So essentially, these have a ceiling effect. They produce a partial functional response no matter the amount of the drug administered, and these were developed to prevent the phenomenon of drug abuse or drug overdose. So buprenorphine is a partial agonist. Then we come to antagonists who bind to receptors but don't produce any functional response. These are used primarily in drug addiction. Naloxone is one of these. They can also be used in opioid overdose to prevent further symptoms. And then we have agonist antagonists, which are agonist at one receptor, but they have an antagonistic activity at another opioid receptor. Primarily, we end up using the agonists and the partial agonists in our practice. Okay, and now we come to the important part of how does opioid analgesia actually act. And before we look at opioid analgesia, I'm just going to give you a short introduction on some of the pain pathway mechanisms. It's important to remember that we have an ascending pathway and a descending pathway for pain. The ascending pathway is the one that will carry all the pain perceptions from the nociceptors at the periphery up to the thalamus. And the ascending pathway goes via the spinothalamic tract and then goes into the somatosensory cortex. The descending pathway is the excitatory pathway of pain. Is the inhibitory pathway of pain, and the opioid analgesia mainly acts on the descending inhibitory pathway of pain, especially in the PAG area of the midbrain. So the midbrain is where a lot of the opioid analgesics will act. So here, if you see, there is a lot of opioid analgesia acting at the level of the midbrain. The dorsal horn in the spinal cord, which has the substantia gelatinosa. The substantia gelatinosa is basically the area where the first order neuron, the secondary order neuron, the second order neuron, and also the interneurons act. It's where the first order neuron will secrete the substance P, which will then go up in the ascending pathway. So what opioids do is that they will enhance the descending pathways from the brain because these are inhibitory, and then therefore you will have reduced pain transmission. They will reduce the pain transmission in the ascending pathways at the dorsal horn of the spinal cord, and they also act at peripheral nociceptors. And so these are the 3 main areas where the opioids act to produce opioid analgesia. So we've covered opioid pharmacology, or rather we've covered opioid physiology, and now we move on to the pharmacology. We had already discussed which are the weak and which are the strong opioids. So just to remind you, weak opioids are codeine, tramadol, and tapentadol. This gives some of the recommended dosages that we use for these patients. It's important to know that out of these, codeine is sparingly used. You must have heard about the term, the rapid metabolizers, the ultra-fast metabolizers, and pharmacokinetics becomes complex in codeine. It's much more studied in Caucasian population, not so well studied in the Indian population. So most of our results on pharmacokinetics we have extrapolated from Caucasian population. And that's because of these complex pharmacokinetics, it's very difficult to predict which patients will be able to metabolize codeine and which patients will not be able to metabolize codeine. If they are ultra rapid metabolizers, the drug will there will be an increased concentration of the drug in the system. And if they are slow metabolizers, there will be very little concentration of drug in the system, and hence there will be no analgesic effect. So that's about codeine. And then we come to tramadol or tapentadol. Tramadol, the dosage is 50 to 100 milligram thrice a day or 4 times a day, and a maximum of about 400 milligrams per day. I'm going to come to all these individual opioids also. And then tapentadol is also given at a dosage of 50 milligram 4 times a day. We have a little less data on tapentadol as compared to tramadol because tramadol has been in the market. So there's a lot of post-marketing studies on tramadol, a lot more than tapentadol. So that being said, it's considered quite an effective drug, tapentadol, although we don't have enough data yet. It's still being used quite frequently. Okay, so this one I think we will be covering up. Codeine. Codeine is an opium alkaloid, which is about 1/10 as potent as morphine. It's partly a prodrug. So codeine gets biotransformed to morphine, and this is CYP2D6 associated. Bioavailability is around 40% because I spoke about the differing metabolisms associated with codeine. Codeine is primarily used for antitussive properties. I still find some doctors using codeine. I think there is a tablet called Narcogen Fort, which is quite popular or had been quite popular many years ago and is still being used sometimes. But it's not really recommended to use codeine for pain relief because we have much better, much stronger drugs now. It's going to be tricky to use codeine in renal failure because we don't know how much morphine will get accumulated, and accumulation of morphine in renal failure is dangerous. And so that's basically how we use codeine. Its use is being more or less phased out by. When it comes to tramadol, tramadol is a synthetic, but it's a centrally acting analgesic. It has both non-opioid and opioid properties. So that's one of the plus points or the advantages of tramadol, that along with the agonist effect at the mu-opioid receptor, it also inhibits presynaptic uptake of serotonin and norepinephrine. And so here you will find that tramadol also has some neuropathic effect. And this is why you might have patients in which you might get very good pain relief with tramadol. And these will be patients who have both nociceptive as well as neuropathic aspects of pain as their symptom. So this could be something like malignancies with nerve entrapment, which will be both nociceptive as well as neuropathic components. So tramadol is also effective as a cough suppressant, although it's hardly ever used exclusively for that. It's lesser constipating, causes lesser respiratory depression. We'll come to overall side effects of opioids later. Maximum recommended dosage is about 400 milligram per day. It's got a decent bioavailability of 65 to 70%. There are some areas in which we need to exhibit caution for tramadol. So epilepsy, head trauma, and raised ICT. And this is because tramadol lowers the seizure threshold. And also you have to exercise caution if you're using it with medications with other medications that lower the seizure threshold. So antipsychotics, other opioids, SSRIs, all of these medications. SSRIs and TCAs, actually you exhibit caution because tramadol itself is also going to cause presynaptic reuptake inhibition. Strength of tramadol in comparison to morphine, I'm coming to that. There is a good table up ahead. Tapentadol is a centrally acting analgesic with a dual mode of action. It's an agonist at the mu-opioid receptor, and it's a norepinephrine reuptake inhibitor. So now we see that both tramadol and tapentadol have some neuropathic effect to some extent. There are quite a few opioids which do also have additional neuropathic effect. We'll get to each of them and we'll describe that as we get to them. Its analgesic effects have been compared to tramadol, but its potency is somewhere between tramadol and morphine. So, actually, it's been mentioned in literature that you can use tapentadol for severe pain also, not just moderate pain. But usually, we end up using morphine for severe pain, and tapentadol we use for mainly moderate pain. The recommended doses for adults is 50 to 100 milligram as needed every 4 to 6 hours with a maximum dose of about 600 milligram per day. I think the previous one was a mistake. For mild to moderate hepatic or renal impairment, there are no dosage adjustments. So that's an advantage there. Okay, so we've completed weak opioids and now moved on to strong opioids. So moving on to morphine, which is the gold standard of treatment for cancer pain, and these are WHO guidelines. Basically, when palliative care was first established, most of the palliative care was focused on cancer, and it is only later on that palliative care kind of encompassed to include non-cancer or non-oncologic conditions also. And so a lot of the guidelines that were WHO guidelines around cancer, a lot of the guidelines, the WHO guidelines around pain were in the context of cancer only. And so that's why in a lot of this literature, you will find a lot of cancer pain going on and on. But that's not to say that there are other respiratory conditions which will require pain management also. So oral morphine, gold standard for pain management. Two major metabolites in oral morphine: M3G, morphine 3-glucuronide, and morphine 6-glucuronide. M6G is the active component, and that's the one that goes and binds to the receptors. M3G is also sometimes responsible for a neuroexcitatory effect, and sometimes there can be CNS side effects associated with morphine, which M3G will be the cause. Now, the main receptor targets for morphine are the dorsal horn of the spinal cord and the PAG matter in the midbrain. And morphine has about 35 to 40% oral bioavailability. The duration of action of morphine is 3 to 6 hours, which is why most morphine most immediate release morphine formulations are given every 4 hours. So, but we do find this disparity that in some patients the dose effect wears off after 3 hours, and in some patients the dose effect may require about 6 hours to wear off. Morphine does not have a ceiling dose, and dose should be, it's a pure agonist. The dose is titrated according to the pain. A lot of the strong opioids like morphine, fentanyl, methadone, fentanyl, sometimes we tend to say we don't really give beyond 4 micrograms per kg, but morphine, methadone don't really have a upper limit and a ceiling dose. One reason that they say is that basically your dose will be titrated to the side effects that the patient is experiencing, but they don't have a narrow therapeutic window. So what we say is that there are more and more opioid receptors usually recruited, and then in cases of severe pain, and then that's the reason why dose may need to be increased and may need to be titrated. So the one drawback of morphine is that it has a slow penetration of the blood-brain barrier because of low lipid solubility. And so that's why it's not always as effective in pain because of raised ICT or intracranial pain or headaches, although it's still used to some extent. So starting a little bit of opioid prescribing at this point. Most commonly, the strong opioids that we will be giving will be morphine. So the starting dose in either an opioid naive patient or a frail or an elderly patient is going to be 5 milligram 4-hourly with PRN or SOS doses. If the patient is already receiving a weak opioid like tramadol or tapentadol, the starting dose will be 10 milligram 4-hourly with PRN or SOS doses. And the PRN dose is going to be about 1/10 to 1/6 of the 24-hour dose. Common practice wise, usually whatever is the single dose is used as a PRN dose. So if a patient is on 10 milligram 4-hourly, then even the PRN dose is usually used as 10 milligram. It's important to remember that 4 hours is the duration of action. This is not a very common frequency of administration of any medication, and so we may tend to reduce the dosage. We may tend to get scared about the fact that we are giving at intervals at such short intervals of 4 hours, and so we may want to reduce the frequency and give it 6-hourly or 8-hourly, but ideally the frequency at which it has to be given is 4-hourly, and this is based on its pharmacokinetics. Now, patients are always taught about PRN dosage because, as I said, initially a lot of the pain management was around cancers, and breakthrough pain can happen quite often in cancer-related pain. We may also have something which is called as incidental pain, that is pain associated with any kind of particular activity, pain associated with any kind of movement. Patients with apical mass or apical sort of brachial plexopathy can have incidental pain when they are moving the arm, but they may require to do this at certain points of the day or for any kind of activity, and so SOS doses becomes important. If a patient is receiving only about, say, 2 to 3 SOS doses in a day, we usually leave it at that. But if the patient is requiring more than 2, so 3 or more SOS doses in a day, we then usually recalculate the 24-hour dose and then divide by 6 to change the dose. So if, for example, a patient is on 10 milligram 4-hourly, that makes it a total daily dose of 60 milligram. So if a patient is on 10 milligram 4-hourly, that makes it a total daily dose of 60 milligram. Now, if that patient has taken 3 extra doses for 2-3 days at a go, that makes the 24-hour dose 90 milligrams. So 90 milligram divided by 6 would be 15. And so the revised prescription for this patient would be 15 milligrams 6-hourly plus PRN. So that is basic prescription of morphine. That's how a basic prescription of an opioid like morphine would be. Then there are 2 or 3 other things to be thought of along with morphine. Sometimes in opioid naive patients, it can cause 2 to 3 days of nausea and vomiting. So some practitioners give a prophylactic antiemetic, haloperidol, domperidone, metoclopramide, any of these, giving it as 2 to 3 days. It's important to remember that 5-HT3 like ondansetron and MSET and all will not really work for MSs related to morphine. It's going to be more domperidone or haloperidol which will help. And so this is sometimes given as prophylaxis for about 2 to 3 days. There is also constipation, which is an enduring side effect of morphine, and that has to be a laxative, usually always has to be given alongside morphine. And so a typical pain prescription of morphine would be that there is a saying in palliative care that the hand that writes the opioid must also write the laxative. And so along with morphine, you will always end up giving a laxative, preferably a stimulating laxative rather than a bulk forming one. So something like bisoprolol rather than say isfagula husk or something like that. Because basically there is stasis. Morphine slows down the gut transit, and so the problem that is causing constipation is not roughage or it's not fiber. It's low gut motility. Okay, now we come to caution in renal and liver function. In renal function, even with mild to moderate renal failure, it has to be administered with caution. So, because morphine is excreted via the urine, mostly in renal function, we either try and switch to another. We either try and switch to another opioid, or we would reduce the dose of the drug. Most frequently, we reduce the frequency. So instead of giving 10 milligram 4-hourly, we may end up giving 10 milligram 8-hour. In liver function, usually it's Chalpak C, where we would, reduce the dose or the dosing for morphine. So this is all about morphine. Before we move to fentanyl, any questions about morphine, if anybody has? I just need a minute.
Can you explain more about on a sustained release morphine?
Okay. I think that the slide for the sustained release has gone down. Just 1 minute. Yeah, here you go. So these are the formulations of morphine that are available. We have morphine formulations in the form of oral and IV. So oral and parenteral both can be given. Oral route, we have what is known as immediate release and we have what is known as slow release. Immediate release is the formulation which I just spoke about, which has a 4-hour half-life. And so that is available in 10 milligram, 20 and 30 milligram. And for slow release is usually given every 8 to 12 hours. Usually a BD dosage is what is given for the slow release formulations. When you start a patient on pain management, you will start with the immediate release formulation always. You will make sure that the patient has stable pain on the immediate release formulation before moving to a slow release. And even with the slow release formulation, the SOS dosage which you will give will be the immediate release formulation. So slow release is available as 10 milligram, 30 milligram, and 60 milligram. And slow release formulation, the dose that you give is going to be equivalent to the morphine total daily dose. So if this patient is getting 15 milligram 4-hourly, that means the total daily dose of morphine is 90 milligram. How you will give it is, it's going to be difficult to give you 90, but say the patient's total daily dose is 80 milligram, you will give 40 milligram BD. So the total daily dose, including the slow release formulation, will end up being will end up being the same as the total daily dose of the immediate release formulation. So that's with respect to the oral route. It's also important to remember that you can break the immediate release, but not the slow release, because if you break the slow release tablet, it becomes an immediate release tablet. Any patient who is getting slow release formulation, the SOS dose or the PRN dose is going to remain the same. It's going to be an immediate release tablet. So you will then end up prescribing this patient both slow release morphine as well as immediate release morphine. And then you have the subcutaneous or the IV route. The IV medication is also used as subcutaneous medication. I'll cover subcutaneous towards the end once I finish all the opioid formulations. The IV morphine sulfate is available in 10 mg per ml and 15 mg per ml. A lot of times the IV route is used as a way to reduce either acute pain, if a patient comes to you with an acute pain situation and you are just trying to ascertain the dose of morphine that is going to be useful for the patient in the long run. Or it can be used in case a patient is unable to take oral formulation completely. Now, usually how we give the IV morphine trial is that if you have a 15 mg vial, you will dilute it in 10 ml, and you will, so that will make it 1.5 mg per ml, and you will keep giving doses of 1.5 or 2 milligrams until the patient attains pain relief. And so if I end up giving 3 doses of 1.5 every 10 minutes, that means that the patient's total dose requirement is 4.5. Now, 4.5 multiplied by 3 is how much? It's going to be somewhere like 13 milligrams or something like that. And that's going to be the oral dose of morphine. So the conversion rate from oral to IV morphine is 3:1. So 1 milligram of IV morphine equivalent to 3 milligram of oral morphine. I hope I'm not going too fast. If I am, please stop me and ask, because I'm just sharing a lot of details. I think Dr. Farhana has written that there is I'll repeat, there is an opioid conversion guide. So you want me to repeat the how to give an oral, how to give an IV morphine trial? We take IV form. Yeah, we take a 15 milligram vial. It will be 1 ml per 15 milligram. We dilute 1 ml in 10 ml saline. So that makes it 15 milligram per 10 ml. So that's what your syringe will have. And that means 1 ml will have 1.5 milligram. And for any patient in pain, we will give 1 ml at 10-minute durations. This is for any patient coming to the casualty or to the palliative care center in acute pain. So we will give 1.5 milligram every 10 minutes until the patient attains pain relief. Now, suppose a patient has come to me and I have given 3 doses of 1.5 milligram, and then the patient says that now I have pain relief. So that means that the amount of IV morphine that this patient required for pain relief was 4.5 milligram. And so that is the IV formulation. If I have to continue this IV, I would give this patient 4.5 milligram IV 4 hours. But I'm going to be sending this patient home, and I need to convert this IV into oral formulation. And so I will multiply 4.5 by 3. So that will be something like 13.5 milligram. If I round it up, I will usually round it up to maybe I can give 15 milligram or I can start with 10 milligram actually, and then maybe increase to 15 if needed. So I will give that in the oral formulation. I will give that 4 hourly as a oral medication. Dr. Farhana has also put this in the chat. Okay, any other doubts on morphine? One other thing that I wanted to add is that if I am writing a prescription for morphine of 10 milligram oral morphine every 4 hours, during the day, it's fine because the patient can take 10 milligram every 4 hours. But in the night, my patient may not want to wake up in the middle of the night to take the morphine. And so the usual practice is to give a double dose at night. So this means that they will take their last dose, their night dose will be a double dose. So it will be 2 tablets of morphine rather than 1 tablet, and that will ensure continued pain relief for the next 8 hours.
Madam, can't we use the SR in the night instead of double dose?
So my main rationale for giving immediate release is that the pain may be unstable. and that I may want to change my dose of morphine. So usually what I will do is I will give the patient an immediate release morphine for a few days to a few weeks, reach a dose of morphine wherein
Not
the
about
patient
about the night I am talking about. Instead
I
of
know.
doubling the dose, you can give SR in the night, and rest of the day you can take the.
I mean, technically it is possible, but I also want to avoid. I also want to avoid adverse effects like drowsiness, and so for me, in the beginning, an immediate release of morphine is the best way. Okay. Any further questions, or shall we? Okay. So from morphine, we now move to fentanyl. Fentanyl, the indications for using is chronic stable cancer pain where oral morphine cannot be used. So again, even with fentanyl, you require that the cancer pain be stable or the pain be stable. So chronic stable pain where oral morphine cannot be used, uncontrollable side effects of morphine, and renal or liver failure. Because fentanyl is safer to use than morphine, especially for renal failure. Fentanyl has lesser constipation, nausea, and vomiting, so it's preferable in cases of obstruction. Anywhere where a lot of GI side effects you are either anticipating or the patient already has, it may be a better choice. It's highly lipid soluble. It's delivered better transdermally and sublingually as compared to morphine. That's why you have the transdermal formulation of fentanyl. Lesser withdrawal symptoms with fentanyl. And the most common utilization, at least in the OPD basis of fentanyl, will be the patch, which is the 12 microgram, 25, or the 50 microgram patch. Fentanyl is also available as IV and as buccal formulations. I'm sure you are all familiar with the use of fentanyl as IV formulations. It's used a lot in the ICUs. Also, it's used a lot even in the OTs and by anesthetists. But the buccal formulation is usually a fentanyl lollipop, and that was introduced for pain relief for children. And this was supposed to be pain relief for children for procedures or short-term pain relief. But the delivery is inconsistent, and the lollipop is actually not really available in India for utilization. Now, some important things to keep in mind when we are prescribing the fentanyl patch is that I've mentioned are there in this chart. You have to mark the site of the patch with the date it was applied, because usually we use it for 72 hours. And so if a patch has been applied at 5 p.m. today, then it will be changed at 5 p.m. after 72 hours. Try and apply it to dry, flat, non-hairy skin on the torso or the upper arm. So you have to look at areas which are non-hairy. Usually we advise patients and families to rotate the area. So if one day it is on the right side of the chest, then the next time you change it, it should be on the left side of the chest, and then you can move to the back, and then keep rotating the areas and not do it in one area also. Also, sweating will interfere with fentanyl absorption. So that's another thing to note. Also note that you cannot cut a fentanyl patch and use just the half. The delivery is not going to be half of the dose of the fentanyl patch. And so it's going to be inconsistent, and you won't know how much drug is delivered. And duration of action of fentanyl, it takes about 12 hours once the patch is applied for the fentanyl to get to steady state concentration in the body. And this means that even after removal of the patch, you will have to wait for 12 hours for the drug to completely leave the system. Okay. Coming to adverse effects of transdermal fentanyl, actually, I think the slide came before the total adverse effects slide that I'm coming to like overall opioid adverse effects also. But these are more or less these are the overall adverse effects of opioids. So we have drowsiness, we have dizziness, we have headache, insomnia, nausea. Drowsiness and nausea vomiting usually are what we develop tolerance to it, and so they may last for a few days and then disappear. Constipation is one side effect which does not disappear. And then you can have sometimes muscle rigidity when given IV with often. Now, other side effects could be abdominal pain, anorexia, anxiety, diarrhea, dry mouth. We have a lot of cholinergically mediated side effects also. So visual disturbances, palpitations, sweating, vasodilation. And topical effects like you can have occasional skin irritation with the fentanyl patches itself. So moving on from fentanyl to buprenorphine, but just before that, talking a little bit about the IV fentanyl and the IV fentanyl either as bolus or as infusion. So IV formulation, it's usually available as 50 micrograms in per ml or per 2 ml. We usually, if we are giving a bolus dose of fentanyl, we will give somewhere like 0.5 to 1 microgram per kg. So anywhere between 25 to 50 micrograms is going to be a bolus dose for SOS pain relief. But a bolus dose, although the duration of action is within a few minutes, it will last for up to just about a few hours, 2 to 3 hours, and it's not going to be a medication that you can give as regular bolus doses. Usually, fentanyl is used more in terms of IV infusion. The starting dose which we use for pain is anywhere between 0.3 to 5.5 micrograms per kg, and we can usually go up to 3 to 4 micrograms per kg, and this is per kg per hour dosages. Okay, moving on to buprenorphine. So buprenorphine, as we had read before, is a partially agonist antagonist. It will have an analgesia effect at the lower plasma concentrations, and that is again mediated via the mu receptor only. But at higher concentrations, it has an anti-analgesia effect that's mediated by the kappa and the delta. So this is because the reason buprenorphine is more sort of easy to use is because that there is a lower potential for respiratory depression, because there is a lower potential for overdose in general. Buprenorphine, because there is anti-analgesia, there will be a ceiling effect, and buprenorphine is also safe to use in renal failure. So we come now to the last opioid medication, which is methadone. Methadone has a longer duration of action. Usually we give it about at 8-hourly intervals. It has higher oral bioavailability. It also has anti-NMDA activity, and that's why it has a very good potent neuropathic effect. But methadone has complex pharmacokinetics. The dose of methadone that the patient needs to be initiated upon depends on the total daily dose of morphine or morphine equivalent that the patient is taking. So the higher the dose of morphine, the lower it's not uniform how we increase the dose of methadone. So if we need to give methadone, you need a lot more training in pain and pain management to be able to give methadone. So usually pain physicians undergo, or palliative care physicians undergo a lot of training before actually starting to use methadone. There are worksheets, and there are sort of tables that will tell you at what dosage of morphine do you give what dosage of methadone. If required, I could share those with you, but it's not a direct action. Okay, so introducing strong opioids for ongoing pain. How do we actually start prescribing, or how do we start giving patients pain relief? Usual indications for ongoing for pain management for strong opioids is pain unrelieved by the non-opioid analgesics. The starting dose, as I had discussed, depends on the previous opioid exposure, the age, and the severity of pain. And just to remember, continuous pain requires continuous or background analgesia. I just got Dr. Farhana, if we have only 30 minutes left and there is a case presentation, then how would you like to? Sorry, I just
Ma'am, it's up to you. If we want, we can go ahead with the session and we can, we don't need to go for a case presentation. If you have a lot of information to share, yes, we can definitely go with that.
So I'll tell you what, I can finish about 10 minutes and then we
Okay.
can go ahead with case presentation. We can.
Yes, sure, ma'am. Sure.
Because most of these are, this is things that I've already discussed. So I can maybe start with breakthrough dosing and then.
Yes,
Okay.
ma'am. Yes,
So
sure.
breakthrough pain is, as I discussed, that pain that occurs over and above the regular pain management that the patient is undergoing. So the patient may be on a regular frequency of pain dosage, and there can be a flare that goes above that. So this is where you will give your SOS or extra dose of analgesic. This is, as we had discussed, that is 5 to 15% of the 24-hour dose, or one single dose can be given as breakthrough pain. So these are some of the adverse events that are associated with opioids. Gastrointestinal, these are mainly because of low gut motility. So nausea, vomiting, constipation. Autonomic symptoms are because of cholinergic activation. So you have urinary retention, xerostomia. You can have some postural hypotension, which can contribute to dizziness. CNS-wise, you have drowsiness, cognitive impairment, hallucinations, delirium, insomnia, respiratory depression. All these are CNS side effects of opioids. Sometimes you have myoclonus and hyperalgesia, which is the CNS hyperexcitability part of opioids, which I was discussing, which is M3G mediated. And for these, you may need to reduce or even stop the opioid medication. So this is one of the adverse event which is sort of to look out for. And then cutaneous, there is itch and sweating that can be associated with opioids. Now, this bit I think we already covered. Okay, so the perception that there is that use of opioid analgesics for pain will cause addiction is a prevalent myth. You have to know how to differentiate between true addiction and pseudo addiction. So pseudo addiction is basically just a reaction to undertreated pain. So it's a craving for the opioid, which is caused by undertreating pain, and it's education is the key to be able to do an effective pain management. Tolerance to side effects is observed commonly, and some side effects which have tolerance are sedation, nausea, and vomiting. Tolerance to analgesia is not as common, but opioid switching can be an option when the patient becomes tolerant of one opioid and may need and still need pain. So with increasing dose requirement, especially in situations where pain can be quite fluctuating, so that can be cancer-related pain, that can be pain at the end of life also. So look for worsening disease and not pharmacologic tolerance. So the first point of action would be to actually increase the dose and see if it helps. Even with tolerance, some amount of increasing the dose does help. So first try and increase the dose, see if that works, and only then think about tolerance and opioid switching. Okay, now this is an important slide which I wanted to add because it has most of the evidence. I know that and this is my last slide, so we can go to case presentation afterwards. So I know that with respect to especially pulmonary disease, there is a lot of hesitancy with the use of opioids, because there is a lot of discussion about how pulmonary disease can actually use of opioids in pulmonary disease can actually cause respiratory depression. So this is taken from various meta-analysis and various trials. So meta-analysis done in CA lung showed no evident severe adverse events like respiratory depression or sedation with opioids. Meta-analysis in COPD showed no hypoventilation, opioid-related hospitalization, or respiratory depression or death with oral opioids. And there were some papers which looked at COPD with low-dose opioids and benzodiazepines. Now, a lot of the data that we have on opioids is opioid use for breathlessness in pulmonary disease. So breathlessness, the dose which is used is actually lesser than the dose that is used for pain. And so most of these patients require low-dose opioids. It will be anything like 2.5 milligrams every 6 to 8 hours, or or maybe up to 5 milligrams 4 hourly. So low dose opioids, even coupled with benzodiazepines, showed no increased risk of adverse events. And this is the case even with ILD. So low dose opioids with low dose benzodiazepines, no increased hospitalization, no increase in mortality rates. But with higher doses of benzodiazepines, they have found increased mortality. And the main concerns actually for utilization of opioids in patients with respiratory illness is with hypercapnia. This is not really based on documented evidence, but because there is because of the dual effect of hypercapnia as well as opioids, and especially so with IV opioids, it is said that it's better to monitor more frequently in patients with hypercapnia. I think that this is kind of like my main slide, and then we also forgot about the NDPS bit. So the NDPS Act was initially a very draconian act. In 1985, it was started, and there were heavy restrictions on the use of narcotics. This was amended in 2014. So they made a notified list of which are the essential narcotic drugs. They also made the concept of registered medical institutions. So each registered medical institutions, there are prerequisites. And there are each of this has an RMP, or a registered medical practitioner, who is responsible for the safe use. And then there are specific criteria for how to stock them, how to dispense them, how many prescriptions do you need, triplicate prescriptions are needed, how do you maintain the registers, when they are unused or they are expired, how will you dispose of them, even those which are with the patient and then need disposing of. Each hospital has to have their own narcotic policy based on which will delineate how you dispose of opioids. So there has to be training in the use of opioids. The drugs have to be prescribed only by these RMPs. They have to be purchased from authorized chemists or dealers, and there has to be an annual kind of record of how many have been taken in, how many have been utilized, and how many are pending. I'm going to stop sharing now. There is just one question in the chat. If there is somebody who has to present the case while you are starting, sharing, I will answer this question in the chat.
Yes, ma'am. Thank you so much, ma'am. We will proceed with the case presentation. I welcome Dr. Tanushri. Sangeet, can you please project her case?
Sure, ma'am, sure.
Yeah, thank you.
So the question is, how do you increase the dose of IV morphine so that a dying conscious patient passes peacefully in the presence of family members? Will you add midazolam also? What is your advice? I think that this will probably be covered in your end of life session, because usually either palliative sedation or pain relief at the end of life is something that will require a lot of tweaking of medications. So usually we have midazolam infusion along with whatever pain relief the patient is already getting. We may have some other medications along with that, like prokinetics, and how we do it is usually the first time that we start it, we will maybe prepare an infusion for about 3 to 4 hours, assess at the end of 3 to 4 hours, and then maybe prepare infusions for a little longer, so 8 hours or 12 hours or something like that. Yeah, usually you prescribe morphine for about 15 days at a time. If the patient expires, you have to give the family instructions of how to dispose the morphine. What I have usually used in my practice is that after the patient has expired, you have to take the morphine out of the strip and then dispose them, either flush them in the toilet or dispose them in the sink. Thanks. I will now hand over to the case presenter. Thank you, and I hope I did not take the extra time.
Good evening, everybody. Thank you, ma'am. It was an excellent presentation. Am I audible?
Yes, ma'am.
Yes.
Yeah. Good evening. I'm Dr. Tanushree. I'm doing my fellowship in intervention pulmonology. I'm from Kowa Medical Center from Coimbatore. So I'll be presenting a case on COPD. The patient details of this patient, he's a male, 56 years of age, and with the final diagnosis of COPD with type 2 respiratory failure with a complication of moderate pH with secondary viral infection of H1N1 pneumonia. The presenting complaints, this gentleman presented to us with complaints of cough with expectoration, which was purulent, yellow in color since 15 days with progressive shortness of breath since the last 10 days associated with wheezing. Along with that, the patient also developed fever of 5 days duration. Now, reiterating the last slide. So this gentleman, he's a retired government school teacher by occupation with nil comorbid conditions. He's just a known case of COPD who's already dependent on long-term oxygen therapy and NIV overnight. He presented to our EMR with the above presented complaints. That is cough with yellow sputum, shortness of breath and fever since 15 days. So on examination at the time of arrival, the patient was drowsy, he was tachypneic and he was tachycardic as well. Vitals, he was borderline hemodynamically unstable with 90 by 60 mm of Hg of blood pressure. The pulse rate was 130 per minute and the respiratory rate was around 36 per minute. And his hemoglobin was 15 grams per deciliter, that is polycythemia was noted. There was no clubbing, bilateral pedal edema was noted, and respiratory system examination showed bilateral wheeze. And cardiac examination showed a normal S1, S2 and a loud P2. Now, the treatment, the patient was immediately initiated on NIV in the EMR because the ABG showed type 2 respiratory failure. And since the patient respiratory distress did not settle down, the patient was initiated on mechanical ventilation with lung protective ventilation. And was also initiated on IV antibiotics, that is injection piperacin plus tazobactam, 4.5 grams per IV, Q4 6 hourly, followed by pantoprazole, methylprednisolone, injection furosemide, enoxaparin, or oseltamivir, 75 mg BID, because this patient was found to be having H1N1 later on. Nebulization supportive medications were continued. And the relevant investigations such as ABG, CBC, RFT, CRP, ESR, ET cultures, CT screening of the chest, 2D echo, throat swab, and nasal swab for H1N1 were sent later on. Now, dealing with the psychosocial aspects of this patient, before the diagnosis, the patient had persistent shortness of breath with wheezing, repeated sick leaves during the tenure of work. The physical care for his anxiety, restlessness, and sleeplessness. After the diagnosis of COPD, he felt that maybe I should have quit smoking in the earlier stage. The fear of impending death. Social life was hampered as he was oxygen dependent and he required overnight NIV. And he also felt that why couldn't I get a further better treatment? Now, coming to the psychosocial aspect of this particular patient, his main concerns were regarding his family, particularly his aging mother, his wife, and his single daughter who was pursuing her education, the finances, and the repeated hospital admissions leading to the financial burden on the family and his own suffering as well. Now, coming to the course of the management in the hospital, the patient was, I would like to inform that this patient was extubated to NIV, shifted to the wards with supportive therapy, and NIV was continued. But during the course of stay in the hospital, the patient had repeated ICU admissions. And finally, during the repeated ICU admission, the patient was repeatedly intubated thrice. So finally, the patient family decided to go for DNR and DNI. That is, do not resuscitate and do not DNI, and do not intubate. With this condition, the patient was finally shifted towards on NIV support. Patient had persistent shortness of breath, and hence he was started on tablet morphine 5 mg TID. Now, this morphine not only helped him in his shortness of breath decreasing, but it also helped him in a lot of chronic pain which he developed during this duration of stay. Because even the continuous NIV which the patient was using, the nasal bridge itself was completely excoriated. Finally, the patient, he improved symptomatically and he was discharged with continuous NIV support. The main concern of this patient was the chance of readmission, because over the last 1 year, the patient had repeated hospital admissions, that is around 3 admissions in a year. The recurrent risk of pulmonary infections owing to his underlying chronic respiratory illness, poor lung status because of bilateral emphysematous changes. And to summarize my case, he was a 56-year-old gentleman. He presented to the EMR with complaints of cough, fever, shortness of breath. In view of respiratory distress and worsening hypercarbia, he was intubated. During the course of ICU stay, he was weaned off mechanical ventilation and was on continuous NIV support. He had symptomatic relief with tablet morphine, which he tolerated well, with no adverse effects noted. Now, the main points to be discussed is what else could be done by the pulmonologist, what palliative care can be extended to this patient as a pulmonologist, and what medications could have helped him earlier. Now, coming from a pulmonologist point of view, I would say that maybe if vaccination against H1N1 and pneumococcal vaccination, if I have offered earlier, maybe this infective exacerbation would have been prevented. And coming to the psychosocial care, maybe the concerns regarding his family, aging mother, his unmarried daughter, finances, and his own sufferings would have been better addressed. And physical care for his anxiety, restlessness, pain, sleeplessness, and shortness of breath should be addressed. That's the end of my discussion. Thank you so much, ma'am.
Thank you, Dr. Tanushree, for bringing a wonderful case for discussion. Participants, you can post your questions in the chat box and then we can proceed with the discussion. Already, Dr. Tanushree has posted few discussion points and you can mention your comments on the same.
On discharge,
Ma'am,
whether
if
the
I'm
morphine was
audible, I would
continued.
like to.
Yes, Dr. Tanushree, please go ahead.
Ma'am, actually, from my perspective, I would really like to discuss about morphine, because initially we were very, very reluctant because the patient was already a case of hypercarbia. So, but we reached the end point in this particular case because there were repeated ICU admission in the same sitting. So we were initially very, very reluctant, but morphine definitely helped him because we could see significant improvement in his symptoms. So as you already mentioned, we started him on a low dose. Would that be fine in the further consecutive cases if we can actually prescribe? Not just for the pain management, even for the shortness of breath, if you could.
Dr.
Yes.
Smriti, ma'am.
Yeah, that's why I'm asking whether the morphine was continued after the discharge also, or it was stopped.
So he actually came a month, sir, with the continuous support for a month. He has been using it.
Okay,
We did
good.
continue it because he symptomatic relief, definitely.
The patient can be continued on longer term morphine. So 5 mg thrice a day is like a 15 mg per day dose. So that's quite a low dose of morphine. There are, I think, by now enough trials in COPD, breathlessness in COPD, which talk about long-term use of low dose morphine and as a adjunct medication for breathlessness. So yes, I think the answer to your question is yes.
Ma'am, if there are no further queries, I have another question which is regarding to pain, ma'am. So when we
Yes,
usually
ma'am.
place an ICD or something, like even for malignant pleural effusions, we usually place an ICD or an intrapleural catheter which stays for a very long time for the malignant pleural effusion cases. So these kind of patients, when they are hospitalized, we usually go for a fentanyl patch or a bovular patch that's around 10 mg, 10 mics per hour, if I remember. So I would like to know if the duration of action of fentanyl you have mentioned is 72. So can we repeatedly change the fentanyl patch if required?
Yeah, yeah. So you are talking about pain, this is a kind of acute pain that is
Yes, ma'am.
associated
Acute
with
pain, ma'am.
ICD
Yes,
or
ma'am.
something like that.
Yes, ma'am.
Fentanyl patch is okay to be given and to be changed every 72 hours. I mean, for it to work, you have to change every 72 hours. So you can give it for a longer period of time. In any patient with acute pain, if I am giving them opioids for that, my concern would be that once the pain relief or once the reason for the pain has subsided, I am going to taper and stop that medication. Now, if it's a fentanyl, you will usually just stop the patch and not continue. But usually for patients who you are giving morphine for 2 weeks or more, you will end up tapering it before you stop it. So acute pain, which is associated with, say, procedures or lines or catheters, if you are prescribing opioids for them, you have to stop them before the patient leaves the hospital, or maybe within a few days of the patient getting discharged. But pain which is related to cancer and chronic pain, that is where you may end up giving longer term opioids.
Okay. Thank you, ma'am.
Do we so this discussion that these discussion points, I think since we have about 10 minutes, we can take these. I think that the first two questions are kind of similar, so I'm going to take both of those things together. Apart from pain and breathlessness relief, I think there are some other things that the pulmonologists themselves can offer in terms of primary palliative care for this patient, one of which would be a goals of care discussion and advanced care planning for this patient. If this was a patient that was on long-term follow-up with a pulmonologist or a pulmonology team, explain to them that COPD is a progressive condition and the use of ventilators is actually an informed choice for patients with COPD. It's not something that they should be put on without discussing the pros and cons of ventilation and what it means for them in the long run. So having that goals of care discussion, I in my practice come across a lot of COPD patients who upfront have decided or told their family that they never ever want to be on a ventilator. And this may not just be because they have COPD, this may just be their preferences with regards to treatment. So having an advanced care planning discussion with the patient and the family when they are well, when he is well, talking about, say, what can happen if he needs to be in the ICU, if he needs to be on the ventilator. Those are, I think that would be one of the most important things that the pulmonologist could do with the patient. And there is a lot of research to show that patients prefer to have discussions about their goals of care, about their preferences with respect to ICU, with respect to ventilators. They prefer to have this in advance. It's not that this scares them or they don't go back to the doctor after that, or they feel that the doctor said something untoward. And a lot of times they would prefer to have them with their primary physician. So the physician that they are comfortable with, that they have been going to for so many years, that is the physician that they trust. And so I would say, in my experience, goals of care discussion, advanced care planning discussion happens best in that situation. One, when the patient is well, and two, by the primary care physician who is taking care of them. And so in a patient with COPD, that would be the pulmonologist. I think we will be having a discussion on this in the future. Isn't that right, Dr. Farhana?
Ma'am, we have a session on end of life care, then palliative care in the ICU. So,
I
and
see.
then we have tuberculosis and pulmonary rehabilitation. That is the upcoming session.
Okay. Another thing I think that then needs to be discussed is the phenomenon of advanced care planning and actually writing down your care preferences for treatment. I don't know how many people are aware of this, but the Supreme Court has laid down judgments on how you can have a living will and how you can write down your care preferences, and this is applicable to anybody. They can do it even in their pink of health, but this is something that definitely should be discussed by pulmonologists with pulmonologists and their patients. So maybe making a living will or making an advanced care document, informing the family members and all the doctors involved in their care of their goals of care preferences. These are some of the main things that that I think that could have been done by the pulmonologists. I know that you've already mentioned about Dr. Tanushree has already mentioned about the psychosocial care, finances, some amount of spiritual support is also something that the pulmonologist can offer. It's sometimes like talking about spiritual care or the spiritual aspect of suffering can be daunting, but just a few simple questions like, how are you coping? This disease has been, you have been going through this disease for such a long time. How are you managing? How is your family managing? Just saying these questions and giving a listening ear, and the patient can actually be able to discuss with you a lot of things. So yeah, those are my inputs. Any other questions?
I can't see any questions in the chat box as of now, and I don't see anyone raising the hand also. If there are no more questions, I think we can close the session for today. Yeah. Thank you so much, Dr. Smriti ma'am, for joining us because it was such an extensive session, but you made it very simpler and for patiently answering all the questions till the end. Thank you so much for dedicating this evening for all of us. Thank you, ma'am. Over to you, Sangeet.
Thank you, ma'am. Thank you, Smriti ma'am, for the wonderful session. Thank you, Dr. Krudala Tanushree, for presenting a wonderful case presentation. Thank you, Ashwin Doctor, for facilitating the MDS sessions this far. Thank you all for participating. Thank you. Let's see you in the next session.